Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information you hear. Now, look at the notes for extract 1.
Extract 1. Questions 1 to 12. For questions 1 to 12, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Hello, doctor. May I come in?
Yes, please, be seated. May I know your problem?
Well, I'm a patient with marginal B-cell lymphoma, for which I had a splenectomy 2 years ago. But last year I developed a diffuse large B-cell lymphoma that was treated with CHOP reduction. The disease again went into complete remission.
Okay, then what happened now?
I was doing well until recently, a few days ago, late last week, when a swelling developed on my left testicle. I had fevers and chills for the past few days, and I felt weak.
What's your age?
45, doctor.
Do you drink or smoke?
Well, I used to smoke and drink, but I quit completely.
Your previous illness and surgeries?
I had B-cell lymphoma and diffuse large cell lymphoma. I had splenectomy.
Are you taking any medications?
No, doctor.
Are you allergic to any medications?
No, doctor.
May I know your family history of illness?
Well, my mother had paralysis before she died at 70. My father is deceased at the age of 84 of a head and neck cancer. My 56-year-old brother with type 2 diabetes and blindness, secondary to diabetic retinopathy. My 41-year-old younger brother has hypertension, and my younger sister has thyroid disease.
Okay, well, as per the laboratory data, your white blood count is 13.8, hemoglobin 14.3, hematocrit 42.4, platelets 235,000, SMA7 shows a potassium of 3.9, glucose is 213. Physical examination shows no conjunctival pallor or Icarus, no adenopathy, no corticoid bruits, lungs are clear, no gallop or murmur in heart. Your right testicle is markedly erythematous and swollen and tender. Endocrine shows symptoms of type 2 diabetes mellitus. You have left testicular swelling. It is tender. Etiology, possible epididymitis, or possible torsion of the testes. You have a history of diffuse large cell lymphoma and remission. You have a history of marginal B-cell lymphoma. Status post-splendectomy 2 years ago. You have a history of diabetes mellitus. I recommend that you have the ultrasound tests done for scrotum and abdomen. I will ask for CT scan of abdomen and pelvis after seeing the ultrasound reports. I am prescribing IV antibiotics. See me once you receive the ultrasound test reports. Extract 2. Questions 13 to 24. For questions 13 to 24, complete the following notes with a word or short phrase. You now have 30 seconds to look at the notes.
You hear a doctor talking to a patient.
Hello, doctor. Good morning.
Yes, good morning. What's your problem?
Well, doctor, I have a sinus problem. I get postnasal drainage, facial pain, headaches, sore throat and congestion.
Since how many days have you been facing this problem?
For the past 2 weeks, doctor. I'm also getting snoring, teeth pain and nasal burning.
Is it moderate or severe?
It worsens in the evening and morning.
What's your age?
47, doctor.
Did you have any illness previously or any surgeries?
Yes, surgeries, gallbladder and hernia.
Do you drink, smoke?
I don't drink, but I smoke 1 pack of cigarettes per day for the past 15 years.
Any of your family members have any illness?
Yes, I have a family history of allergies and hypertension.
What are the medications you are taking?
Claritin, Dilantin and Rhinocort nasal spray.
Are you allergic to any medicine?
No, doctor.
Well, your auricle's external auditory canals reveal no significant abnormalities bilaterally. TM's intact with no middle ear effusion and are mobile to insufflation. Your intranasal exam reveals moderate congestion and purulent mucus. Your oropharynx examination shows teeth, alveolar ridges reveal missing molar. Examination of the posterior pharynx show a prominent uvulva and prominent postnasal drainage. The palatine tonsils are 2+ and cryptic. The palpation of anterior neck reveals no tenderness. Examination of the posterior neck shows mild tenderness to palpation of the suboccipital muscles. Facial examination shows there is bilateral maxillary sinus tenderness to palpation. Waters View X-ray reveals bilateral maxillary mucosal thickening. You have acute maxillary sinusitis 461.0. Snoring 786.09. Well, I am prescribing you Augmentin, 875 milligrams twice a day, and Mucofen, 800 milligrams twice a day. Follow these medications for 3 weeks and meet me after that. If the conditions don't improve, then I will order a mini sinus CT.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25. Now read the question.
All right, so real quick, Mrs. Craig is a 65-year-old female. She's 1 day post-op from a total abdominal hysterectomy. No known diagnosed allergies. Vital signs have been stable today, although we've had some pain control issues. 0.5 milligrams at the allotted, Q2 hours. Last one was at 6:30, next one will be at 8:30. Okay? Liquid diet, orders to progress to a regular diet as tolerated. As well as starting oral meds as soon as she can tolerate a regular diet.
Has she been eating?
Not that I've seen today, no. She does have IV, normal saline running, 50 milliliters per hour. Okay. SCDs are applied as per policy. She has a Foley catheter. I believe that's about it. Do you have any questions?
Okay.
Question 26. Now read the question.
Bedside shift report is so important, not only to our patients, but to our staff. It creates a transparency of communication that is shared between the two caregivers in front of the patient and engaging with the patient and family if the patient requests. This allows for the patient to hear the information that is being shared and ask questions when those occur. It also allows us not only to confirm the goals that we have for the patient, for their healing and their recovery, but it allows us to engage with our patients and ask, what's the most important thing for you? What can I do for you today to make your day better?
Question 27. Now read the question.
You indicated that it was at a 7 and you're not due to have more pain medication until 8:30. And so what I'm going to do is I'm going to go back once I'm done greeting all my patients, and I'm going to check to see if there's anything the doctor has ordered for you that we might be able to give you in addition to the Dilaudid that you're already receiving. Many times physicians will order different kinds of pain medications that patients can take concurrently. I'm glad that you're splinting using the pillow to press down when you're coughing or sneezing. That also helps with pain control. Now, another non-pharmaceutical way to control pain, help alleviate it, is actually activity. It might seem counterintuitive, but making sure that your body is moving and that you're using your muscles actively helps control the pain. So if possible, I'd like to get you up this evening. Maybe if nothing else, just walk to the bathroom or maybe walk to the door and then back again. I think that might help.
Question 28. Now read the question.
In a perfect world, we'd rather that our patients not have to use the call light or even call us on our telephone. And one of the ways that we endeavor to do that is through hourly rounding, when either myself, a nurse, or a patient care tech will check on the patients.
Perfect. So when you press that red button, it rings at the unit desk, and someone will come on the line and ask what you might need. Does that sound like something you can do?
I can do that.
Terrific. So what I'm going to do next is update my name and number there on the board, all right?
A patient always feels better the more information they have, and we strive to do that, for example, with our communication board. We actively update the communication board and point to it as a way for them to call us whenever they need help with something or have a question that needs to be answered.
Question 29. Now read the question.
We utilize hourly rounding and bedside shift report not only to enhance the patient experience by creating a safe environment and a healing environment for them, but it creates trust in the care team that is caring for the patient. Our eye care values integrity, compassion, accountability, respect, and excellence are mirrored in these efforts as we create an exceptional care experience for every patient and family member, I might add, every day with a spirit of warmth, friendliness, and personal pride.
Question 30. Now read the question.
We set a comfort goal for 3. What's your pain level at right now, Mrs. Craig? On a scale of 0 to 10, how do you feel?
About a 7.
About a 7. Okay. She's on a liquid diet.
Is she taking anything for the pain?
She is. She has ordered 0.5 milligrams of Dilaudid IV as needed every 2 hours. And she did receive that about 6:30. I updated the board, so the next one due, Mrs. Craig, would be about 8:30 this evening. She's also been using splinting, which has helped with the abdominal pain. She's on a clear liquid diet with orders to progress to a regular diet as tolerated.
Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1. Extract 1, questions 31 to 36. You hear an interview with Dr. Helen Sands about her work with patients who are learning to cope with amputation. You now have 90 seconds to read questions 31 to 36.
I'm joined today by Dr. Helen Sands, who works with patients who've had limbs amputated. Now, amputation is an extremely traumatic experience for patients. Helen, in your experience, how do younger patients tend to react to it?
Well, in a range of ways, depending on whether the loss was expected, if it was due to chronic illness, or to something sudden like an accident. One of my young patients in that situation, let's call him David, said losing his leg suddenly was like the pain of an unexpected death in the family. And although this didn't really apply to him, for many young people, even watching a football game can make them feel shut out of activities they once took for granted. But then others come to terms with the fact that for them, normality will be something different from what it was before the operation.
And patients can still suffer pain from a missing limb, can't they, even after the limb's been amputated? What's called phantom limb syndrome. How common is this?
Well, the phenomenon was first observed many years ago in soldiers who'd lost a limb in combat. The majority reported pain coming from the missing limb. Obviously, surgical techniques have improved, but a large number of amputees still report suffering from a degree of pain from the missing limb. In a few instances, this might be due to a poorly fitting prosthetic, for example, or residual limb pain, but the majority of cases are harder to explain. And patients are reluctant to talk about it in case medical professionals doubt their mental state, so it's not very easy to say just how often it occurs. However, I still tend to think it's large numbers.
And you must have come across examples of this phantom limb syndrome in your own patients who have missing limbs.
Oh, yes, of course. Many patients report feeling as if the missing limb is still attached to their body, even years after the amputation. Some patients have reported actually trying to use it just as they did before. And in the case of other patients, they feel as though the missing limb is permanently at an abnormal angle, and they have to make allowances for it when moving around. I've come across a number of instances of that. And other patients experience what we call telescoping. The sensation that the limb is still there is normal, but it's become smaller, shrunk somehow.
And I understand that you have a treatment trial going on in the hospital at the moment.
Well, yes. I mean, in the normal course of treatment, we administer analgesia, and we also make use of local injection therapy using pain-blocking agents. Unfortunately, though, these don't always work as well as we might like. So we're working with a group of patients who have reached the point where the pain's badly affecting normal activities such as sleeping and going to work. All patients in the group have suffered from phantom limb pain for 10 years on average. So they're the most extreme cases we could find.
So how did you set about treating the patients in the trial group?
Well, when a limb is lost, that affects a number of brain functions, and we wanted to try to restore those functions. So we attached electrodes to the remaining muscles of the stump and then asked patients to try to move the phantom limb. And patients could view their virtual limb moving on a computer. But they couldn't just imagine moving the limb, they actually had to force their brain, if you like, to perform the action. Because only then would these circuits, these pathways, be restored in their brains. So the patient controlled the virtual limb just as they would have with their own limb. And slowly, they got better at doing this in a way that was productive to the brain. And patients invariably reported that as a result, their pain diminished.
So the treatment was useful. Does it have any other advantages?
Well, we followed up patients after different periods of time, and the improvements were still there, but not to the same degree. But the decrease in pain levels was still statistically significant. But this kind of treatment is very easy for patients to do at home once they've left the hospital. They only need a computer with a webcam and the program.
And this research is ongoing, of course, so we can look in more.
Now look at Extract 2. Questions 37 to 42. You hear the monologue of a physician giving a lecture on the hemolytic anemia. You have 90 seconds to read questions 37 to 42. Hello everybody. I am going to explain to you different types of hemolytic anemia. Hemolysis is the breakdown of red blood cells that typically has a lifespan of 120 days. After this duration, they die and break down. One of the main functions of red blood cells is to carry oxygen to every part of our body. Therefore, in case the red blood cells break down abnormally, there will be very few of them to carry oxygen to our body parts. Certain diseases and conditions cause red blood cells to break down too early, resulting in fatigue and other more severe symptoms. There are different types of hemolytic anemia, and the conditions can be either inherited or acquired. Let me explain to you certain disorders and conditions of different types of hemolytic anemias. Inherited hemolytic anemias usually occur due to a faulty gene that controls red blood cell production. While moving through the bloodstream, abnormal red blood cells may be fragile and break down. Sickle cell anemia is a severe inherited disease where the body produces abnormal hemoglobin, causing the red blood cells to have a crescent or sickle shape. Sickle cells usually die within 10 to 20 days, as the bone marrow can't produce new red blood cells fast enough to replace the dying red blood cells. In the US, sickle cell anemia mainly affects African Americans. Thalassemias are the inherited blood disorders where the body can't produce certain types of hemoglobin in adequate quantity, causing the body to produce less healthy red blood cells. Hereditary spherocytosis occurs when the outer covering of red blood cells, called the surface membrane, is defected. In this condition, red blood cells have an abnormally short lifespan and a ball-like or sphere shape. Hereditary elliptocytosis or oval cytosis causes a defective cell membrane in which red blood cells are abnormally oval in shape, are not as flexible as normal red blood cells, and have a shorter lifespan than healthy cells. Glucose 6-phosphate dehydrogenase deficiency occurs when the red blood cells are missing an important enzyme called G6PD. The lack of enzyme causes the red blood cells to rupture and die when they contact certain substances in the bloodstream. For the patients with G6PD deficit, severe stress, infections, certain drugs or foods can cause the destruction of red blood cells. Certain examples of such triggers include aspirin, anti-malaria drugs, sulfur drugs, non-steroidal anti-inflammatory drugs, naphthalene or fava beans. Pyruvate kinase deficiency is caused when the body is missing an enzyme called pyruvate kinase. And with this condition, the red blood cells tend to break down quickly. Acquired hemolytic anemias occur when the hemolytic anemia is acquired. In this condition, although the red blood cells may be normal, certain disease or other factors will cause the body to destroy the red blood cells in the spleen or bloodstream. With immune hemolytic anemia, the immune system destroys healthy red blood cells. The three main classifications of immune hemolytic anemia are autoimmune hemolytic anemia, which is the most common hemolytic anemia condition. For some unknown reason, this disease causes the body's own immune system to produce antibodies that start attacking our own healthy red blood cells. This disease may become severe and grow very aggressively. Alloimmune hemolytic anemia occurs when the immune system attacks transplanted tissues, a blood transfusion, or the fetus in some pregnant women. This disease can occur if the transfused blood is a different blood type than our own blood, and it can also occur during pregnancy when a woman has rhesus negative blood and her fetus has rhesus positive blood. Drug-induced hemolytic anemia occurs when a medicine triggers the immune system to attack its own red blood cells. In such case, one may be drug-induced hemolytic anemia. Chemicals in medicine, such as penicillin, can attach to the red blood cell surfaces and cause the development of antibodies. Mechanical hemolytic anemias cause physical damage to red blood cell membranes, which can cause destruction at a faster rate than normal. The damage may be caused by changes in the small blood vessels or due to the certain medical devices, high blood pressure during pregnancy called preeclampsia, or a condition that causes seizures in pregnant women called eclampsia. Malignant hypertension or a rare blood disorder such as thrombotic thrombocytopenic purpura that causes blood clots to form in small blood vessels throughout the body. Moreover, participating in strenuous activities can also result in blood cell damage in the limbs at times. With paroxysmal nocturnal hemoglobinuria, the body will destroy abnormal red blood cells caused by a lack of certain proteins more rapidly than normal. Individuals with this disease are at increased risk for blood clots in the veins and low levels of white blood cells and platelets. Certain infections, substances, and chemicals can also damage red blood cells, resulting in hemolytic anemia. For instance, toxic chemicals, malaria, tick-borne diseases, or snake venom.
I wonder. How head injury can lead to a condition like this?
I realize your anxiety. Definitely, I will help you to sort it out. But before moving further, would it be okay if I can ask you some questions?